So, but before going to the hemorrhagic shock, I want you people to know a little about lethal triad of death, because this lethal triad of death is a very common finding which can happen in any of the patient who is in shock. So, the understanding of this actually guides the treatment principles. So, we'll start with the lethal triad of death first. So, before that, as a recap of last class, whenever there's a trauma, so 25% of these patients, traumatic patients, will develop something called as acute traumatic coagulopathy. There's a coagulopathy of the trauma where there is fibrinolysis and there is a fibrinogen deficiency and there is platelet dysfunction and there is hypoplatelet count also. So there is reduced platelet count, there is platelet dysfunction, hyperfibrinolysis and fibrinogen deficiency. This is called as acute traumatic coagulopathy. To this, when we resuscitate the patients, over aggressive resuscitation with fluids, when it is done, that will cause dilutional coagulopathy. We'll see further how this causes dilutional coagulopathy. So this acute traumatic coagulopathy with dilutional coagulopathy is called as trauma-induced coagulopathy. So whenever there's a trauma-induced coagulopathy, it means that there is bleeding. This bleeding eventually has led to trauma-induced coagulopathy. Because there is coagulopathy, it will cause further increase in the bleed. So when the further increase in the bleed occurs, there is further coagulopathy, and that will further accentuate the trauma-induced coagulopathy. When this cycle happens for a long period of time, the body enters into what is called as lethal triad of death. It is a death triad of death. So lethal triad of death is actually consists of acidosis, hypothermia, and coagulopathy. So lethal triad of death is when the trauma patients or land into acute traumatic coagulopathy and are injudiciously or undertreated. Either you overtreat them or undertreat them. Both of that will lead to patient entering a vicious cycle of bleeding and coagulopathy, which further accentuate each other and lead to this state known as lethal triad of death, which consists of acidosis, hypothermia, and coagulopathy. Hypothermia leads to coagulopathy, acidosis leads to coagulopathy, and hypothermia can also lead to acidosis. So, as I told you, to tell acidosis, the lactate levels are important. So, normal lactate level is anywhere between 1 to 2 millimoles. So 2 to 4 is called hyperlactatemia, where there is no acidosis. Once it reaches to 4, more than 4 millimoles, it is a state of lactic acidosis. Hypothermia is defined when the temperature is less than 36 degrees Celsius. To tell it is coagulopathy, I told you fibrinogen deficiency happens, where it is less than 1 nanogram per ml, and the platelets reduce their count to less than 50,000 cells per mmq. And along with that, there is hyperfibrinolysis. Right? So these are the components of lethal triad of death: acidosis of more than 4 millimole, hypothermia of temperature of less than 36, and coagulopathy with fibrinogen levels of less than 1 nanogram, platelet of less than 50,000 with associated dysfunction and hyperfibrinolysis. So now we will take each one of them. First is acidosis. See, whenever there is a trauma, with this trauma, I mean the trauma here all signifies a trauma causing blood loss. Okay. So this trauma will cause anxiety to the patient, obviously. And because of this anxiety and along with the sympathetic stimulation, initially the respiratory rate of the patient is increased, initially for a very brief period of time. So when initially respiratory rate of the patient is increased, this will cause increased carbon dioxide washout. So when the carbon dioxide washes out, actually initially there is a respiratory alkalosis. But because the body, it is in very early stages of the body compensates it by mild metabolic acidosis, which does not require any treatment and is not detrimental. This is fine because initially, because of the anxiety and sympathetic stimulation, there is increase in the respiratory rate. The patient is tachypneic. He loses carbon dioxide through the respiratory system. that leads to respiratory alkalosis, but it is compensated by mild metabolic acidosis, and this is fine, where no treatment is required, nor it is any detrimental. It is just a consequence of the anxiety and sympathetic stimulation. But when this further blood loss happens in the body, this blood loss will, as I told you, reduce the shock. By definition is reduced tissue perfusion, which is inadequate for cellular respiration. So reduced oxygen is available. So when reduced oxygen is available, the cells switch from glucose anaerobic respiration. They ferment the glucose and the end product is lactate that produces acidosis. This is the first reason for acidosis, which is obviously a metabolic acidosis, which signifies that there is a poor perfusion at the capillary level, at the cellular level. So this is first reason for acidosis in trauma. Second, if you resuscitate these patients aggressively with fluids, what happens is the most common fluid used is normal saline and RL. The pH of RL is 6.5 and pH of normal saline is anywhere between 5 to 7. The normal blood pH is considered to be 7.35 to 7.45. Now, when this happens, when these fluids are injudiciously used, they will cause fluid-induced acidosis. Most of the fluids that we use are acidotic in nature and they produce fluid-induced acidosis or resuscitation-induced acidosis. So once the patient develops acidosis, these are the reasons why they develop acidosis. Once they develop acidosis, these patients have this acidosis affects cardiac muscle. So when this affects cardiac muscle, the force of concentration reduces. When the force of concentration reduces, the stroke volume reduces, the cardiac output reduces, and eventually the systolic BP reduces because of the acidosis affecting the cardiac muscle. This acidosis affects enzymes because enzymes in the body can function optimally when they are at 7.4 pH and 37 degrees Celsius. The temperature and the acidity of the blood, the pH of the blood is very important for the enzymes to function. The enzymes can function only when they are at optimum pH and optimum temperature. So if there is acidosis, it affects the enzymes, and most of these enzymes are involved in coagulation. So it will affect the coagulation. That is why coagulation is affected in the acidosis. And this acidosis also interferes with cellular metabolism. So it interferes with the cellular metabolism. It affects the enzymes, especially the coagulation enzymes, and all of this together will lead to coagulopathy. In the treatment of shock, once the pathophysiology is identified, the most important thing in the treatment of shock is to treat the shock itself. All these are the complications of the shock, and the complications of the shock can be curtailed only by treating the shock. Meaning, there is no scope for symptomatic management in shock. Like for example, if the patient has tachycardia is a compensatory mechanism that is produced by a body in shock. You cannot give a beta blocker to prevent tachycardia. Similarly, when there is acidosis, when there is tachypnea to the patient, you cannot reduce the respiratory rate of the patient so that tachypnea is prevented. So it is always detrimental. So whatever the symptoms are expressed in the shock, they are the compensatory mechanisms of the body, and treating those symptoms is actually detrimental and not helpful in treatment of the shock. So the prime principle of the shock to treat in the treatment of the shock is to treat the shock itself. But there is one advantage of, so by this what I mean to tell is, everything that happens, although this acidosis is detrimental, there is one advantage of this acidosis, that is when hemoglobin saturation of oxygen. So you take a red blood cell and you put it into a acidic media, it actually delivers more oxygen. So what acidosis does is, acidic environment, it removes the oxygen from the hemoglobin at a cellular level. So this is a cell and a hemoglobin molecule carrying oxygen has come here. In the presence of acidic environment, this actually causes more release of oxygen than in alkaline environment. So acidosis in that way it is helpful. But ultimately, if you don't stop acidosis, it leads to coagulopathy and bleeding, and this keeps on continuing. So, can anybody tell me if you get a patient of shock, you get a ABG done, and there is acidosis, what is the treatment that you want to give? You know that there is metabolic acidosis in this patient. What do you want to do? Hello, hello, hello. Any patient who comes to you with a shock, and because of this shock, the patient has metabolic acidosis, you do not rush and give soda bicarb, right? Because when you give soda bicarb, this soda bicarb in the liver is converted into carbonic acid, which further is converted into water and release of carbon dioxide. And this carbon dioxide increases intracellular acidosis, which actually worsens the condition. So, soda bicarb is contraindicated in any patient with acidosis with shock. Right? So, this is one, irrespective of the pH levels. But what happens is you do not treat this if the coagulopathy keeps on happening. So, there is one molecule which is called as THAM. Now, this THAM molecule can be used when the pH is too low because it does not release the carbon dioxide, right? So, it can be given. But the prime treatment of acidosis is to correct shock. You identify the cause of shock, you take care of the cause of shock, it will treat the shock, right? So, this is about acidosis. Next is hypothermia. So, why does trauma or blood loss cause hypothermia? For this, we need to understand how heat is generated in the body, right? So we are all homeothermic animals, meaning our core temperature in the body remains same irrespective of the changes in the external environment. So the room temperature is normally around 22 to 27 degrees Celsius, but whatever be the change in the external environment, our core temperature remains at 37 degrees Celsius. Now, to maintain this 37 degrees Celsius, there has to be constant heat production in the body. And the most important thing for production of heat is ATP. When this ATP is utilized, it gets converted into ADP, which further gets converted into AMP. When this happens, it is releasing the phosphate bond. Release of this phosphate bond is a exothermic reaction, meaning this will release the heat. So consumption of ATP releases heat. In other words, ATP is needed for the production of heat. So this is one way by which heat is produced because of presence of ATP. Second is we are constantly burning calories even if you are not doing anything. That is called as basal metabolic rate, which is around 75 kilocalorie per hour. Now this happens because of the consumption of ATP again, which is indirectly utilization of the ATP, which is enhanced by various hormones like thyroid hormone, catecholamines, all these hormones, epinephrines, they enhance this basal metabolic rate, which is actually indirect way of utilizing ATP. And the third is the thermogenesis. So when we need to generate more heat, the body utilizes either of the two. One is shivering thermogenesis, non-shivering thermogenesis. When we need to produce heat, we need to break down ATP. If we want to break down ATP, we need to consume ATP. So what body does is it causes the stimulation of the muscles. These muscles will contract, and when they contract, they utilize this ATP. When they utilize this ATP, they release the phosphate bonds, which are exothermic reaction, and they produce heat. Also, this is called as shivering thermogenesis. Shivering thermogenesis can produce up to 250 kilocalorie per hour of heat. Right? Now, non-shivering thermogenesis is what happens in a brown fat, where there are lot of sympathetic nerve endings. these will cause uncoupling. So because of this uncoupling, the substrate is directly converted to heat and there is no ATP production. Without ATP production, it produces heat directly. That is non-Fourier thermogenesis that happens in the brown fat. Now, heat is measured in calories, energy is measured in calories. So, 1 calorie of energy is what is required to raise the 1 ml of water's temperature by 1 degree Celsius. Right? If you want to raise the temperature of 1 ml of water by 1 degree Celsius, what energy you require is called as 1 calorie. So you can put it as 1 kilocalorie is the energy required to raise the temperature of 1 liter of water by 1 degree Celsius. Right? So now the human body is made up of seven. You consider an average human of 75 kg. Assuming that entire 75 kg is water only, you need 75 liters of water. So you need 75 kilocalorie to raise this temperature of 75 liters of water by 1 degree Celsius. But because we are not entirely made up of water, we take a specific heat coefficient of 0.8. So if we multiply this zero point 0.8 into 75, we get around 62 kilocalorie. Meaning, for a average adult measuring 75 kg, 62 kilocalories of energy or ATP is required to raise the temperature by 1 degree Celsius. So if we want to raise the temperature of a human being by 1 degree Celsius, we need to spend 62 kilocalorie. Meaning, if we lose 62 kilocalories, we reduce the temperature by 1 degree Celsius. So when there is no ATP production, because when the acidosis is first step, where the body is fermenting glucose because oxygen is not available. Next, when even the glucose is also not available, there is no ATP production. When the ATP production reduces, the body loses heat. So every 62 kilocalorie lost is a degree Celsius which is lost, right? So this is how hypothermia happens in trauma. Clear? Hello? Hello?
Yes, sir.
We classify this trauma-induced hypothermia. There is a different classification for spontaneous hypothermia. So we classify this trauma-induced hypothermia as mild, moderate, and severe. So any patient coming to in trauma, try to check his or her temperature, and if it is less than, if it is in the range of 36 to 34, it is mild. 34 to 32, it is moderate. Less than 32 is severe hypothermia. So this has mortality rate increased by 4 times, and this mortality is increased by 7 times, and less than 30 to 100 times of mortality is increased. So what are the effects of hypothermia? So if the patient develops hypothermia, what happens? As I told you, hypothermia affects enzyme activity and it affects coagulation cascade. The most heat sensitive factors are 3 and 12. 3 is a tissue thromboplastin factor. 12 is a Hageman factor, which is a contact factor. Right? So a factor 3 and factor 12 are the most common factors which are affected by hypothermia. So when there is enzyme activity and when there is a inhibition of the coagulation cascade, that eventually leads to coagulopathy. And because there is hypothermia, it also inhibits the cellular metabolism, which also contribute to acidosis. And this acidosis eventually contributes to coagulopathy. And this cycle keeps on happening. So one cause for hypothermia was trauma induced. Second is, if you injudiciously resuscitate these patients with fluid, most fluids are stored at room temperature. You do not preheat these fluids and you transfuse these fluids, that produces fluid induced hypothermia because you are not preheating. Fluid also plus blood products also, blood and blood products, if you do not preheat them, that produces hypothermia. The third is, if the patient's cavities are open, You do a laparotomy for these patients, and after laparotomy, the bowel surface walls are all exposed, the peritoneum is exposed, there is a increased loss of heat that produces hypothermia. So when the heat loss occurs from the body, the heat loss can occur by conduction or by convection or by radiation. If heat loss can occur by conduction, convection, and radiation, it means that we can give heat to the body by conduction, convection, and radiation also. Right? So, what is conduction is if I take a solid and this has one, two, three, four molecules. If I transfer heat to this molecule, it will transfer to the next molecule, and next molecule, so that the heat from point A reaches to point B without the actual movement of the molecules. All the molecules are in contact with each other. They do not actually move, they just conduct the heat. That is called conduction. Convection is what is if when you boil water, you can see all these small bubbles, which these bubbles which are here, they receive most of the heat energy. They come up to the surface, and in the surface they transfer the heat. So here from point A to point B, there is actually a movement of the molecule. That is convection. So out of this, conduction is the best method of giving the heat to the patient, because air is a very bad convection current, right? Because the air has so low density, the air molecules are very far from each other. So the molecule, each molecule has to travel a lot of distance before it can give its energy to the next molecule. That is why by convection, it is not such a good media. So conduction is a very good media. Radiation is also a very good media. So the most thing that we exploit in treating these patients is the utilization of the conduction. Right. So this is about hypothermia. Now we need to know how to treat hypothermia, because you don't treat hypothermia, it leads to coagulopathy, leads to further shock. Can anybody tell me what would be the most effective way of treating hypothermia because of shock? Hello, hello.
Treating shock.
Very good. So the most effective way to treat any of the complication is to treat the shock itself. So now we have two methods of treating hypothermia. One is passive method and another is active method. So passive method is you should prevent the further hypothermia in the patient. So to prevent further hypothermia, first is this is very important. Avoid cold fluids. Do not always try to, if facilities are available, always try to preheat the fluids before transfusion. And while doing laparotomy, if you want to give laparotomy lavage or the laparoscopic lavage, always try to use warm fluids so that hypothermia is not exaggerated. It is one. Second is you cover the patient, especially the head has a very large surface area where it can emit heat. So especially cover the head with a aluminum based linens. You get linens which are coated with aluminum. So try to cover the head of the patient with the aluminum coated linens. And the third point in passive resuscitation is dry the patient. Because when these patients come, there will be a lot of secretions over the patients and there is a lot of bleeding of the patients. You try to dry the patient. And the fourth most important is treatment of shock. Fifth is you warm the room. This is because I don't know if you have an idea about this. There was an experiment in physics that we usually used to do in the pre-university course. So where if there was a liquid of 40 degrees Celsius and your aim was to reduce this liquid to 35 degrees Celsius and note down the time it takes to reduce it to 35 degrees Celsius. Similarly, there was a fluid of 35 degrees Celsius and you needed it to reduce to 30 degrees Celsius. While the room temperature was around 22 degrees Celsius. Now here also you are reducing it by 5 degrees Celsius. Here also you are reducing it by 5 degrees Celsius. but this reduces faster compared to this one. Now, this happens because the gradient between the temperature of the fluid and the temperature of the room is more here and it is less here. So, the greater is the difference between the temperature of the fluid and the ambient temperature, faster will be the heat loss. Meaning, if greater is the difference between the temperature of the patient and the room temperature in which the patient is there, faster will be the heat loss. So, one way we are trying to warm the patient, and the other way is you warm the room so that the temperature difference reduces and the amount of loss of heat also reduces. So, that is all these are the passive methods of treatment of hypothermia. Now, the active method is you are giving calories to the patient. You are giving heat to the patient to reduce it. So, the active methods would be either it is external and it is internal methods. So, externally, you need to warm the patient. So, how can you warm the patient is radiant warmers. So, patient is placed and above him a radiant warmer is placed and that will provide radiation of light and that will warm the patient. So this is by radiation. Second is there were pets called as bear huggers. Right? Bear is the name of the scientist who described this. So it is a bear hugger. Bear hugger is where there is a patient and this patient is wrapped in a plastic cover. Of course, head will be open. So he is wrapped in a uh, cover which is disposable, a blanket which is disposable, and this is connected to a hose and that is connected to a machine. So this machine will send the heated air, a warm air into here. So this warm air will go and it will warm the patient, but this is by convection because the air is traveling and warming the patient. So that is why it is not a very good effective method, but yet it can be used. A bear hugger can be used. And then there is heating pad. So under the bed of the patient, you keep a heating pad. So where if this is the patient and under the bed of the patient, you keep a pad where it contains water, warm water. So this also causes the transfer of the heat to the patient by counter current heat exchange. Right? So this transfers the heat to the patient. The in patient also the fluid is moving and there is water in this heating pad also. So there is exchange of heat between the water of the patient and the water in the fluid. That is counter current heat exchange system by heating pad. We also have beds called as clinitron beds. Clinitron beds. So clinitron beds are basically used to prevent the bed sores. So these beds, what they contain is they contain these small pockets of silicon which is in microspherical form, and when the humidified air is passed through that, it is converted into a fluid. Right? This is called as air fluidized system. You pass air through the silicon microspheres, it converts those spheres into the fluid by heating them, and that heat is transferred to the patient. So, air fluidized therapy or the systems is what it is used. It can also be used as a air bed for the patient to prevent bed sores. So these are all the external things by radiation, by bear hugger, by heat pad or clinitron beds. But we have very good insulation in the form of skin and subcutaneous tissue. So if skin and subcutaneous tissue cannot let the heat outside of the body, they cannot also let heat into the body also. So it is not a very good effective method to warm the patient by using external warmers. So the best method would be to use internal warming. So how to warm the patients internally? You give a warm fluid as IV. Whatever fluid you want to give, you preheat them to 39 degrees Celsius. And then only you give it to the patient where the facilities are available. That is warm fluid in the form of IV. You cannot preheat the blood, but what you can do is in some centers there are fluid set warmers are present, right? Meaning you cannot, if you get a PRBC from the blood, you wait it till it reaches the ambient temperature, the room temperature, but then again you cannot place it into a heater and heat it. So what you can do is once you connect the blood, whatever the drip is there, the drip can be enclosed in a fluid warmer. So as the blood flows into the patient, it gets warm. So you can use these fluid warmers which are available in certain centers. One. So you give warm IV fluid. Second is you give warm air. For example, if the patient is connected to the ventilator, anyhow you are giving air, you are adding humidified air into that. Also warm the air. So you preheat the air and you give a warm air if the patient is on ventilator, if the patient is on mechanical ventilation. But again, this is by convection. When it is by convection, it is not an effective method. And third is you can give warm lavage also. So you have put IV rice tube to the patient, you send a warm fluid inside and you aspirate it out. You have put a Foley's catheter to the patient, you send warm fluid through the Foley's and you aspirate it out after 10 to 15 minutes. You have inserted a chest tube to the patient, you send a limited amount of fluid so that it will not cause respiratory distress. Keep it for 10 to 15 minutes and then you take it out. So warm lavage is also method of keeping the patient internally warm. And fourth is you can use ECMO. ECMO is extracorporeal membrane oxygenation, which is like an artificial lung. You take blood from the patient, you pass it through this ECMO machine, which is an artificial lung. And along with giving oxygen to this blood, it will also give warmth. It will send the blood becomes preheated and you send the blood back to the patient. So that is ECMO. Or you can use a cardiopulmonary bypass. All these are, if there are other forms of shock like cardiogenic shock is also associated, you can use this ECMO and cardiopulmonary bypass. Then is venous rewarming, which is nothing but dialysis of the patient. You take blood from the vein of the patient, warm it, just like in diagnosis, dialysis, you purify it, you warm it, give it back to the patient. But of all this, the most effective method is arteriovenous warming, where you take blood from the femoral artery, you pass it through a warmer, and you give it back into the femoral vein. By this arteriovenous warming, you can achieve the warming up to 37 degrees Celsius in 39 minutes. So this is the most effective of all the types of the internal warming. But remember to treat the cause of shock, which assumes the prime importance upon management. So this is hypothermia. In any patient with hypothermia, it is very essential that you treat the hypothermia and you prevent further worsening of the hypothermia. Right. And finally, the third component is coagulopathy. Now, this coagulopathy, as I told you, one is because of acidosis, there is coagulopathy because the enzymes do not function. And second is hypothermia because here also the enzymes do not function and the coagulation factors are affected. And third is consumptive coagulopathy. When the patient is bleeding, all the factors will be utilized to stop the bleed. Because all these factors are utilized and there is no reserve in the body to generate more factors, there is coagulopathy. That is called as consumptive coagulopathy and dilutional coagulopathy. This is because of the fluids that you give. When you give these fluids will cause acidosis, they cause hypothermia, and they cause coagulopathy. So these are the causes for coagulopathy in a trauma patient: acidosis, hypothermia, consumptive coagulopathy, and a dilutional coagulopathy. Right. So once there is coagulopathy, that will lead to bleeding, and this bleeding will further aggravate the coagulopathy, and this vicious cycle ensues. Right. Now, how to can anybody tell me how to investigate a patient? What investigation would you like to do if you want to know that whether the patient is in coagulopathy or not? Hello, hello. So PT, EPTT, PTT, INR. So these are good tests to be performed. But what happens in body is that This coagulopathy is a dynamic state. So as soon as there is trauma, there is hypocoagulopathy. This hypocoagulopathy is followed by hypercoagulopathy, and then there is fibrinolysis. And you do this PT, APTT, INR, they are prolonged also. You do not know whether to keep the patient on fresh frozen plasma, whether to transfuse platelet to the patient, whether to give cryoprecipitate to the patient, or whether to give prothrombin complex concentrate. So, a better investigation, if available, would be TEG or rototem, right? TEG is thromboelastogram, tech, and rototem is rotational thromboelastometry. So rotatum and tech are better investigation than PT, APTT, INR because they guide you in giving what treatment also. So I want to clear you people this thing. So blood, Venkatesh sir, please mute your audio. So blood contains plasma, right? So plasma actually contains all the clotting factors, which is fresh frozen plasma. So fresh frozen plasma contains all the clotting factors. The platelet prothrombin concentrate, prothrombin complex concentrate, especially contains 2, 7, 9, 10 with or without factor A. And this is best induced if there is a warfarin induced coagulopathy, right? So anywhere there is a deficiency of clotting factors 2, 7, 9, 10, prothrombin concentrate is a best used. And the cryoprecipitate is actually the precipitate of the fresh frozen plasma. You take fresh frozen plasma, you trickle down all the plasma from that. What you get is a cryoprecipitate. Cryoprecipitate is rich in fibrinogen. It is rich in fibronectin. It is rich in von Willebrand factor, factor 8 and factor 13. So this you need to remember. So fresh frozen plasma contains all the clotting factors. Platelet prothrombin complex concentrate is especially 2, 7, 9, 10, and the cryoprecipitate is got after trickling down all the plasma from the FFP. It is rich in fibrinogen, fibronectin, von Willebrand factor, and factor 8 and 13. So if you want to know what factor you need to give, because the treatment of coagulopathy is very important. You don't treat coagulopathy, shock cannot be treated. So control the bleeding, along with that, try to treat the coagulopathy. So out of all these three factors, hypothermia, acidosis, and coagulopathy assumes the prime importance. So now to treat this, you need to know a little about thromboelastogram because now this has become a routine investigation in most of the institutions, good institutions. This has become a routine investigation. That is why you need to know about thromboelastogram. So what happens in thromboelastogram is, so there is a cup like this into which you add a blood. So you take a venous blood, you mix it with citrate, and a citrated blood is added to this. And there is a needle here. Now this blood should start to form a clot. So when it starts to form clot, only when the clot is formed, the needle starts to oscillate. It is set such that as the clot forms, the needle oscillates. As the strength of the clot increases, the needle keeps on oscillating more and more and more. But after some time, the clot undergoes lysis, there's fibrinolysis of the clot, and the needle oscillation gradually reduces. So for some time, there is, and this a computer prints this onto a graph paper. So for some time, there is till the clot formation has started, the needle will not move. Once the clot starts to form, the needle starts to move. As the clot increases in its strength, the amplitude of the oscillation of the needle also increases. It becomes bigger and bigger, tries to oscillate more and more. And after a period of time, the clot reduces in size. The strength of the clot reduces and the needle also reduces movement. And then it becomes flat. Right? This is the graph. So if you put this graph like this, so this becomes somewhat a graph like this. This is called as a graph of a thromboelastogram. Now we'll discuss. So the first part, this part, where what is this part? this is where the needle has not moved. It means the formation of clot has not started yet. So from this point to this point, whatever the time is taken, this is called as R time. So R time is the reaction time where it is the latency period before the clot has started to form. And when it increases, once the clot forms, the clot needs to get stabilized. So from here till this, when this graph is plotted, this is time here and this is the amplitude here. The needle has to oscillate till an amplitude of 20 mm. So when it oscillates till an amplitude of 20 mm, till that time, what is taken for the needle to reach the height of 20 mm, this is called as kinetic time or K time. So R time represents the latency period for the formation of the clot. K time represents the time required that the clot attains a desired strength, that it is effective. Now, when the needle keeps on oscillating, if the clot keeps on forming faster, the needle keeps on oscillating faster and the graph assumes a curve like this. But if the rate of formation of clot is slow, the graph will assume a curve like this. So, this angle to the horizontal is called as alpha angle. Now, this alpha angle tells us the rate of the formation of the clot. And next is it reaches a maximum amplitude and then it starts to slow down. So the maximum height that this thromboelastogram can reach is called as maximum amplitude. So this is the maximum height where the clot is at its strongest. So till here, so this is R time till here. From here to 20 mm height, this is K time, this is alpha angle, this is MA. Till here, the clot has formed. So this is coagulation. If any problem happens here, it is called as a coagulation problem. Now the clot declines. So when the clot declines, at the 30 minutes, you measure the amplitude of the graph clot. So it was around 100 mm here. Here it got reduced to 70 mm. It means that the graph has lost its amplitude by 30 mm. So it is called as L by 30. L by 30 means at 30 minutes, we'll confuse, we take it as 80. So 20. So at 30 minutes from the reaching of maximum amplitude, what is the amount of reduction, percentage of reduction in the strength of the clot? So that is L by 30. You can also get L by 60, right? So is this clear? Hello, hello.
Yes, sir. Yes, sir.
So this is R time, K time, alpha angle, maximum amplitude, and L by 30. So by definition, R time is the latency between the process of initiation until the clot has started to form. So it is a latency between the time which is taken for the clot to start to form. So once the clot has started to form, the time it takes to stabilize. So it takes to reach a certain desired height of 20 mm of amplitude. That is called as K time. Alpha angle is the angle at which the graph rises with the horizontal, which actually represents the rate of formation of the fibrin. Maximum amplitude is the maximum height that the graph can attain before it starts to decline, which represents the strength, highest strength of the clot. L by 30 is the percentage of reduction in the amplitude of the graph compared to the maximum amplitude, which represents fibrinolysis. So till that time it is coagulation. R, K, alpha, Ma, they are coagulation. L by 30 and L by 60 tell us the fibrinolysis. You put a graph, you know where the problem is. So if the problem is in coagulation, you correct coagulation. If the problem is in fibrinolysis, you treat fibrinolysis. So what are the normal values? So once you start the process, the clot has to start to form within 10 to minutes. And once it has started to form within 1 to 3 minutes, it has to reach the desired height. And the rate of formation should be such that you get an angle of 50 to 70 degree, right? So it is actually 53 to 75. For purpose of ease, I have made it 50 to 70. Now, the maximum amplitude attained should be at least 50 to 70 mm, right? So because these two remain same. So 50 to 70 degree has to be the angle, 50 to 70 mm has to be achieved. And the At 30 minutes, after 30 minutes of attaining maximum amplitude, there should not be loss of more than 8%, right? So it is 0 to 8 is normal. So up to 8% reduction is acceptable, more than 8 is not acceptable. Now, where is the problem? So the clot has not started to form at all here. So there is a delay in the initiation of the clot formation. So it is delay in the initiation of clot formation because the clotting factors are insufficient. So you need to treat it with a fresh frozen plasma. You do not know which clotting factor. So initiation is only a problem. It can be anywhere from the factor 1 to factor 13. So you need to transfer a fresh frozen plasma which contains all the clotting factors. So once the clot has formed, it starts accumulating fibrin. So to attain desired strength, if fibrin is not accumulated enough, fast enough, it will not attain desired strength. So the rate of progression of the clot and the formation of the clot and the rate of progression of the clot and this K time, both of them depend upon the fibrin levels. It means that there is some problem with the fibrin level. So what do you want to give now? Anybody? Hello. So you want to give cryo precipitate. And again, the amount of maximum height it reaches, meaning the clot remains there for a longer period of time. If it does not reach that maximum height, it means that the clot is not strong enough. The clot is not stabilized enough. And to stabilize the clot, what it needs is a stabilizing factor. This stabilizing factor is actually secreted. Most of these components are secreted by the platelets. So if there is a problem with the maximal amplitude, what you need to transfuse is platelets, right? Because even though there's a problem with the stabilization of the clot, this stabilizing factor, factor 13, is mainly secreted by the platelets. So it means there is some dysfunction in the platelets and you need to transfer the platelets. If the clot got lysed, so if the L by 30, L by 60 have become more than 88%, means in that 30 minutes, only 8% of clot had to be lysed. Now more of this clot got lysed. So when this more of the clot got lysed, it means that there is problem with fibrinolysis. So there is a problem with fibrinolysis. Now, how do you want to treat this fibrinolysis? There is increased fibrinolysis is what it tells. So how do you want to treat? Anybody? You need to give a, the plasminogen in the body is activated to plasmin. This is blocked. This plasmin lyses the clot. Now, this process is blocked by tranexamic acid or epsilon aminocaproic acid. So, EACA or Trenexa blocks this process. Sorry, Trenexa blocks this process. EACA has another mechanism of action. This is actually a lysine metabolite which blocks this process. So, Trenexa can be given. Trenexa is 8 times more powerful than epsilon aminocaproic acid. So, we have reduced the use of epsilon aminocaproic acid and continued with the use of tranexamic acid. Now, that is why you treat coagulopathy depending upon the. So, when it comes to treatment of coagulopathy, the first and foremost is to treat the cause of shock. Then you try to get a tech. Depending on that, you transfuse either the FFP or you transfuse cryoprecipitate or you transfuse the platelets. And third, you inhibit fibrinolysis by giving tranexamic acid. There were trials, crash trials. Crash 1 was use of steroid in the head injury. So according to crash 2 trial, which is a large randomized control study, within 3 hours of trauma, if you start, right, starting tranexamic acid within 3 hours of trauma, not hospital admission. So within 3 hours of trauma, you start tranexamic acid, it improves the outcome of the patient, right? But it has to be started within 3 hours. The first dose is to give 1 gram of Trenexa over 10 minutes. Then you follow it by giving 1 gram of Trenexa over next 8 hours. Right? But it has to be started within 3 hours. More than 3 hours, it is not useful and it is more detrimental. So that is crash to trial. So it has to be started within 3 hours of trauma and give it over 10 minutes. So this Trenexa can also be used topically as a mouthwash, as a intraluminal spray also. This can be used. So the crash 3 trial is actually in progress, and this is has not yet been completed. Clinical trials are not over yet. So this is use of Trenexa in traumatic brain injury. So this is about the treatment of coagulopathy. Is this clear? Hello. Hello.
Yes, sir.
Now you have understood the complete pathophysiology of trauma, hemorrhagic shock. Along with that, we'll start with treatment of hemorrhagic shock. Now, as of now, till now, what I told are the principles of treatment. So the treatment of hemorrhagic shock as per ATLS guidelines, right? Now, according to ATLS, if any patient comes to you with a trauma in this setting is the patient is in hemorrhagic shock. So you are in casualty, a patient came to you with suspected hemorrhagic shock. What is the first thing that you need to do? Anybody? Hello?
Airway.
So whatever it is, the first thing is always airway. Because the most common cause of death, a preventable death in a patient with trauma is airway. So unless you have taken care of airway, the airway can be plugged either by secretions, there can be obstruction to the airway, there can be compression of this airway, or the patient may be a functional patient. It is assumed that if the patient talks, his airway is good. If the patient is unable to talk, there might be a problem with the airway. So you secure the airway. So of whatever it is, if there is a trauma, the first preference is to the airway. Only when you have secured the airway, you go to breathing. The most important step in the treatment of a hemorrhagic shock is to identify the presence of the shock. And second is to ascribe that shock is because of hemorrhage only. For example, you are thinking the patient is having hemorrhagic shock because of a fracture of the femur. The femur fracture is evident, and you think because of the blood loss, the patient is in shock. But the patient can also have associated cardiac tamponade or a tension pneumothorax that is causing the shock. So when it comes between the femoral fracture and the cardiac tamponade or the tension pneumothorax always takes precedence over the any bony fracture in the body. So that is why the second step in the treatment of the shock is to rule out other non-hemorrhagic causes of the shock. It can be because of a neurogenic shock, where there is a transaction of the spinal cord and there is a lot of vasodilation. Or it can be because of a brainstem injury. It can be an obstructed shock because of cardiac tamponade or the tension pneumothorax. Or it can be if the patient has been brought to the hospital very much delayed after the initial trauma, it can be septic shock. So the second important thing is to rule out the shock, especially in breathing, you rule out tension pneumothorax or massive hemothorax. And you give oxygen such that the saturation of the patient is maintained to more than 95%. Then comes circulation. So we'll talk about this. Circulation is what is we are intended to talk about. Then comes disability. So any patient in any kind of the shock will have some amount of neurological disability because the brain is not adequately perfused. The GCS of this patient will be reduced. But remember, isolated brain injury will not cause shock unless there is a brainstem compression. Like if the patient has SDH, which is and EDH or some intracranial hemorrhage, which is not causing compression of the brainstem, or if the brainstem injury has not happened, then if the patient is in shock, do not assume that the shock is because of the head injury. So isolated brain injury, unless the brainstem is involved, will not cause shock. So In such patients, a deterioration of GCS may be because of the shock itself. So that is why once you stabilize the patient, you re-evaluate the patient for neurological disability again. And next is exposure. You need to properly expose the patient so that you do not miss any injuries. But while exposure, make sure that you prevent hypothermia. Then three important things: Riles, Folis. After this, we'll go to the IV. But always it is the circulation, then disability, then exposure. Just for the ease of this discussion. So anytime there is a trauma, these traumatic patients are likely to develop gastric distension. So a patient with trauma and shock, whenever I tell trauma, please assume that it is with relation to the shock. So when the patient has shock because of this trauma, there is every chance that these patients have a distended stomach. So when you get an X-ray of erect abdomen done, most of the times you'll see that there is a gastric distension. Now this gastric distension will cause the stimulation of the vagus, and this vagus will cause hypotension and bradycardia. So that is why it is prudent that you insert a riles. So one of the common sense for inserting riles is that if these patients have aspiration, so riles can try to prevent. It doesn't mean that you put a riles, the aspiration cannot happen. So one is that it will prevent the aspiration, but more importantly, it causes the gastric decompression so that vagus is not stimulated and hypotension and bradycardia do not develop. This is very important. So that you put a riles and connect it to the suction machine. Next is Foley's. So, can anybody tell me what is the precaution to be taken before inserting a Foley's catheter? Hello, hello.
Any bleeding at the tip of the glands?
So, a urethral injury is a contraindication for insertion of the Foley's catheter. So, this urethral injury you suspect when there is pelvic fractures. So, if there is a blood at the meatus, also which is less likely looked is perianal hematoma. Because we do not properly expose the patient, most of the times this perianal hematoma is missed. So you look at perianal hematoma, look at blood at the meatus. If it is there, do not attempt urethral catheterization. You can have a suprapubic catheterization until you have ruled out a urethral injury. Bladder injury is not a contraindication for a Foley's catheterization, but urethral injury is. So that is why you try to look for these conditions, you eliminate them, and then you can put a Foley's catheter. So now comes to IV line. So when it comes to IV line, there is shock, there is ongoing blood loss. Our idea is to, initially at least, rapidly infuse the fluid. So we need to increase the rate of the fluid. So according to Poiseuille's law, the fluid rate is directly proportional to the fourth power of the diameter. So if there is a channel like this, so the time it takes for the fluid to go from point A to point B depends upon the length of this channel and the radius of this channel. So it is common sense that you take a smaller wide bore area, fluid goes faster, and a longer narrower area, fluid goes slower. Right? So that is why it is directly proportional to the fourth power of the radius and inversely proportional to the length. So you choose a wide bore, short length cannula. And in adults, at least choose a 18 gauge cannula and you secure two IV lines. Once you secure two IV lines, you send the blood for routine investigation, blood grouping and cross matching, pregnancy testing, especially if the patient is in a childbearing age group. A female patient in childbearing age group, always try to test for pregnancy. HCG, serum HCG, you get it done, and you get it for ABG and coagulation profile. So all these things you take the blood. If for any reason you are not able to insert IV lines, you either do a venous section of the patient or you put a central line. But these two take time. So till that time, you can use a intraosseous needle. So you use an intraosseous needle, try to transfuse the fluids to this and do venesection or the Central line is better than venesection, and after that you take this out, right? You insert it, you take this out. Central line you can give via internal jugular vein, subclavian vein, or femoral vein. So one thing is, if you are giving via internal jugular vein or subclavian vein, try to get a chest X-ray before, right? Because if the patient has hemothorax or the pneumothorax, you do not know whether this is caused by the trauma or because of an iatrogenic injury. So you do that. Second is, once you insert this, most of the times in trauma, we insert them under aseptic precautions. So better try to reinsert again once the patient is stabilized. You change these catheters. So this is the initial management of ABCDE. So in C, it is that we secure the IV lines and then we proceed further. So once you are done all with this, you send the blood for cross matching. What you need to do is, first you give a fluid challenge as fast as possible. You take a green cannula, it will be around 90 ml per hour of the fluid rate. So as fast as possible, you try to give 1 liter of fluid in adult IV, or 20 ml per kg if the body weight is less than 40 kg, which will be around 800 ml, which is almost same. So first you give a 1 liter of fluid IV or 20 ml per kg if the body weight is less than 40 kg. Then you look for response. Based on the response, you can classify these patients as rapid responders, transient responders, and non-responders. Right? So rapid responders meaning you gave the fluid to these patients and their vital signs return to normal. Here, vital signs return to normal. As soon as you slow down the fluid resuscitation, they again deteriorated. But in non-responders, vital signs never return back to the normal. Right? So what has happened here is, the amount of blood loss in this patient was less than 15%. So you gave a crystalloid, it could manage. Here it was around 15 to 40% of the blood loss, and here it was more than 40%. Meaning these patients were in class 1 shock, these in class 2 or 3, because 2 is 15 to 30, 3 is 30 to 40. And these patients were in class 3 shock when it was initiated. Right? And next is, in these patients, blood loss happened, it was mild, and it stopped. But these patients, blood loss happened and it is still happening, which was moderate. Here, the severe blood loss is just happening, it is draining. Now, next is, these patients may need blood, but not immediately. They may not need blood, but it is very less. These patients eventually need blood. These patients immediately need blood. When these patients need blood, there is a lot of time, so you can get a typing and cross matching. Both type specific and cross matched blood you can give. These patients, there is no time for cross matching. You just give a typed blood. So typing can only be done. These patients, they are already bleeding. They are losing blood. There is no time for even typing. So initiate a massive transfusion protocol. These patients may or may not need surgery. These patients need exploration. These patients need immediate exploration. Right? So we'll further see. So vital signs return to normal is one where you assess this. Second important thing is, you assess the urine output of the patient. So in an adult, the urine output has to be at least 0.5 ml per kg per hour, meaning he is responding to your treatment. In a child, it has to be 1 ml per kg per hour, and in a infant less than 1 year, it has to be 2 ml per kg per hour. Along with that, you also check for urine specific gravity. So the specific gravity keeps on increasing. It means that it is still concentrated, right? And the third thing is, you try to keep the base deficit between +1 to +2 to -2, as I told you in the previous class, and lactate levels. You measure the serial levels of these things, and if the patient is showing consistent improvement, he is a rapid responder. So once you establish that he is a rapid responder, so initially what happened is most of the information that we got for this management of the shock was actually from the US Navy. So, because of this continuous evolution of the wars, there were medics who were highly equipped in all these wars. So, every war that happened from First World War, Second World War, Vietnam War, Korean War, Afghanistan War, Gulf War, in all these wars, every time a war happened, their management strategies kept on changing. So, initially they used to tell resuscitate only with the blood, then they added crystalloid to the blood, then they added to then they came that crystalloid infusion only should be given, then they came to a conclusion that only colloid should be given. So when this happened, out of all this, the only thing that remained for a longer period of time was aggressive colloid resuscitation. So almost for 50 to 70 years, this concept prevailed that any patient comes to your shop, you resuscitate these patients aggressively so that these patients will improve. But it actually reduced the mortality rate, but it increased the morbidity and eventually the patients died. So they did not die on that day, but after 3 days, 4 days, they eventually died. So this happened because when these crystalloids were given at a rapid rate, the patients used to develop ARDS. That was one problem. Patient developed ARDS. Second problem was that giving these crystalloids at a rapid rate and rapidly increasing the BP would have led to the reactionary hemorrhage. As I told you, one of the causes for reactionary hemorrhage is distortionment of the clot. Now, if you raise BP over certain level, whatever the bleeding that had been stopped by non-surgical methods, the clot would get distorted and the patient would go into a shock because of rebleed again. So to prevent that rebleed and to prevent ARDS, they came to a conclusion and the current ATLS guidelines tells that you resuscitate them in a controlled manner. So that gave us the concept of controlled resuscitation, right? That is controlled resuscitation, not exactly DCS. We'll talk about DCS later, where you maintain the patient in hypotension. That is also called as balanced resuscitation or hypotensive resuscitation or permissive hypotension. You permit the BP to remain on the lower side. So controlled resuscitation, balanced resuscitation, hypotensive resuscitation, and permissive hypotension all means same. It means that you resuscitate a patient to a level such that his systolic BP remains less than 110 millimeters of mercury while maintaining tissue oxygenation plus organ perfusion, right? You keep the BP to less than 110 mmHg, but yet you maintain the tissue oxygenation and organ perfusion as evidenced by these things. So you need to monitor these things regularly and try to maintain BP less than 110. So that is why you step down here. Once the patient responds, you step down to maintenance fluids. In a rapid responder, you step down to maintenance fluids. So these maintenance fluids would be given at a rate of 4 ml per kg per hour for first 10 kgs. For next 10 kgs, 10 to 20 kg, you give it at a rate of 2 ml. You reduce it to half per kg per hour. And after 20 kg, for every kg, you give it at a rate of 1 ml per kg per hour. This is how you give a maintenance fluid, right? So in the wards also, pre-operative and post-operative patients try to give maintenance fluid based on this formula. For example, if the patient is 70 kg, you divide the 70 kg as 10 kg, 10 kg, and 10, 10, 20, 50. So first 10 kg it is 4 ml per hour, it will be 40. Next 10 kg it is 2 ml per kg per hour, so it would be 20. And then it is 50. So 40 plus 20, 60, 50, 110. So you give this patient the fluid at a rate of 110 ml per hour, right? And try to maintain the BP to less than 110 mmHg. So this is what is hypotensive or permissive hypotension and resuscitation, where you keep the BP to less than 110 yet preserve tissue oxygenation and organ perfusion, right? So this is one. If the patient responds, but if the patient there was a rapid responder, you cut down the fluid to maintenance fluid, and now he deteriorates. It means that there is some ongoing bleed. So when there is some ongoing bleed, these patients are called as transient responders. And in transient responders, you initiate blood transfusion, right? It means that the patients are in a shock, class 2, class 3 shock, and you initiate blood transfusion, right? Because they're all the factors. You keep on giving fluids to these patients. Fluids will cause hypothermia, fluids will cause acidosis, both of them will cause coagulopathy. The fluids will directly cause coagulopathy. This leads to bleed, and the bleed will cause reduced volume of the blood, and then you resuscitate keeping the fluids. So keeping on giving the fluids will not help you, so you need to initiate blood transfusion, and blood can be replaced by blood alone. So the best thing, if available, would be a fresh whole blood. It has to be fresh and it has to be a whole blood, but most of the times we do not get this fresh whole blood. So acceptable transfusion is a component transfusion. So component transfusion is when it is not anemia. So in anemia, don't try to give fresh whole blood. It is RBCs that is being given, but it is trauma where blood as a whole is lost, which can be replaced only by blood. So what recommendation is given is that if it is available, try to transfuse a fresh whole blood. If it is not available, you can constitute this fresh whole blood by component transfusion, where you transfuse PRBC, FFPs, and platelets. Right? You are getting RBCs, you are getting clotting factors, you are transfusing platelets. 1:1:1. Actually, when they constituted this 1:1:1, the amount of platelet in one pack was very less. Now we get a pooled platelets by apheresis. So now it is actually for every 6 PRBC and every 6 FFP, it is one platelet, right? So every 6 PRBC and every FFP, it is one platelet. But when they made this, it was actually 1:1:1. If that is also not available, at least give a PRBC. This is one about the component. The second thing is, if there is time for typing means which type of the blood, plus cross matching, where you take this sample of the donor, sample of the recipient, and you cross match them. If there is a time available for this, get a typed and cross matched blood. But cross matching takes at least half an hour to 1 hour. So if it is not available, at least get a typed blood. Typed blood means if is A positive, give A positive, O positive, give O positive. If the typed blood is also not available, try to give O type PRBC, and for FFP you can give a AB FFP. Right? This is all based on compatibility. And negative blood is reserved for a female of childbearing age to prevent sensitization. If you know the typing and she's negative, RH negative, try to give RH negative, reserve them. So this is about a blood transfusion. And the patient is a non-responder. So when the patient is non-responder, you initiate blood transfusion by massive transfusion protocol. We'll discuss about this massive transfusion protocol tomorrow. So initiate blood transfusion by massive transfusion protocol. Also, there is a high need for exploration to this patient. This is one. And you need to rule out. You are giving so much of fluids and blood, so you need to rule out other non-hemorrhagic causes of shock. So you need to explore these patients. So where would the blood be present? Where is bleeding happening? So bleeding can be on the floor where it is an external hemorrhage you are seeing, or it is 4 more. So 4 more is essentially a chest, abdomen, and pelvis. Retroperitoneum is given special importance. Retroperitoneum, long bones, and soft tissues. So management of a hemorrhagic shock is stop the bleed and refill the vessel. When it comes to whether you need to stop the bleed or refill the vessel first, the prime importance is always to stop the bleed, right? Because it is the bleeding which is causing all this vicious cycle. Stop the bleed first. Always give an importance to stop the bleed. Till the time you are able to identify the bleed and stop it, keep refilling the vessel. And the best thing to refill the vessel is to by giving the blood. If blood is not available, give blood components, right? And until the time blood is arranged, give a IV fluids. And the last topic for today is, do not confuse damage control resuscitation with damage control surgery, right? So damage control surgery is a different thing. This is a damage control resuscitation because when the patient is in shock because of blood loss, you use them with a improper, aggressive resuscitation, patient will go into triad of death. To prevent that, this concept of damage control resuscitation was introduced. By this damage control resuscitation, they were able to reduce the mortality by 25% and reduce prolonged ICU stay by 9%. They reduced the need for blood transfusion, the greater need for blood transfusions, right? Here also blood transfusion is done, but you aggressively you resuscitate the patient. In future, there would be more need for more blood, right? And mainly they reduce the incidence of the ARDS. So the first point, the principle of damage control resuscitation is avoid overuse of fluid. This cannot be emphasized much. So you do not use the fluid beyond what is necessary. So avoid overuse of fluid. You give 1 liter of fluid, the patient responds, you cut it down to maintenance fluid. You give 1 liter of the fluid, patient responds and then deteriorates, or patient is deteriorating, try to switch to blood. You do not further press it with fluids. So avoid overuse of fluid. Second is avoid cold fluids, which indirectly means you preheat the fluid or blood, whatever you're using, you preheat. Third is, once the patient responds, try to be a permissive hypotension. Fourth, try to use blood as soon as possible. And it also suggests to use 5% hypertonic saline, because 5% hypertonic saline, because the tonicity is more, it will draw fluid from the peripheries and it will put it into the blood. Because it is hyperosmolar, it will take fluid from the interstitial space and it will put into the blood, so that the amount of fluid needed for resuscitation till the time is blood is arranged is very less. So that is why you can use 5% hypertonic saline. But most companies do not manufacture this because it is difficult to get a FDA approval for 5% hypertonic saline. So that is why, but it is still a component where the centers where it is available, especially in USA, they'll use that. But we, if fluids are not, if the 5% estrus is not available and is not responding to the fluid, try to switch to the blood as soon as possible and give prime importance to stop the bleed. So this all concept is based upon the concept of homeostasis. So damage control resuscitation is also called as homeostatic or hemostatic resuscitation. Sorry, it is called as hemostatic resuscitation or a damage controlled resuscitation, where you avoid the overuse of fluid, institute blood early, give importance to stopping the bleed, and always use a preheated fluids. And seventh is try to stop coagulopathy by transfusion of all these factors. It is in fact the summary of this